Good morning, good afternoon, and good evening, social marketers around the world. My name is Patrick Cook, and as the president of the International Social Marketing Association, it is both my privilege and pleasure to introduce the 26th in a series of webinars designed to advance social marketing teaching, research, and practice. I'm here today with Susie Copperthorne and Jay Kassir. Susie is our technical host for the webinar series, and Jay is our moderator as well as the organizer of this webinar series. We're going to begin in just a minute, but before we do, I'd like to share some current updates with you about the International Social Marketing Association. First, we have a new executive for the board of directors of the International Social Marketing Association. I'm your new president. And as of June 1st, Jennifer Wayman is also our secretary, and Kelly Dennings is our treasurer. Of course, we want to pass along our thanks to the outgoing executive team who served for many years as the executive of the International Social Marketing Association, and that's Wynne Morgan, who served as our president and CEO, Craig Lefebvre, who is our vice president, and Tom Bell, who is our secretary and treasurer. I also wanted to let you know that back in May of this year, the board of directors met at the World Social Marketing Conference here in Washington, D.C., and we talked about a new direction for the International Social Marketing Association. I think there was some agreement that we are exploring how ISMA can serve as a hub for the regional associations that are currently in existence, as well as those that are starting up around the world. Of course, we have the Australian Association of Social Marketing, the European Social Marketing Association, Pacific Northwest Social Marketing Association, and the recently established Social Marketing Association of North America. But we also have groups that are starting to put together the framework for new associations in both Africa and Latin America. So we're looking to see how ISMA can support, nurture, and cross-fertilize all of these associations. Also, recently ISMA was invited to participate in a Unicef Led Initiative, and this is an initiative that will try and encourage the adoption and application of social marketing and behavior change communication in the development programs that are led by the UN family of agencies. So it kicked off last month up in New York City. Craig Lefebvre and myself attended on behalf of ISMA, and we're hoping to be a part of this initiative as it goes forward. We actually provided an update on that meeting and next steps for the initiative in our latest edition of the newsletter. So that came out last week. If you haven't had a chance, it would be a great time to take a look at it. So right now, I'd like to turn the webinar over to our moderator, Jay Kassir. Jay?
Thanks, Patrick, and welcome, everyone. I want to remind you that if there are more than one of you at your location, please do let us know how many using the chat box. Also, as we're going through the webinar, as your questions come to you, please do put them into the text box. We will take them roughly in the order that they came in. So don't wait till the end. I think I will skip through those and go right to introducing our speaker today. One more thing actually before you leave the webinar. There will be a poll. So a number of you have been to our webinars before, but it really does help if you take the time to fill out the poll. It's a very short poll, and it just lets us know how we're doing with each webinar. So please go ahead and fill out that poll, which you should get as you leave the webinar. So finally, it's my pleasure to introduce today's speaker, Joy Parkinson. Dr. Parkinson is a lecturer in marketing with social marketing at Griffith University, Australia. Joy has a particular interest in women's health well-being and is a member of the Women's Wellness Research Group, Menzies Health Institute, Queensland. Joy has expertise in individual and household consumer behavior with a focus on health behavior change and maintenance over time, particularly in the areas of food consumption, breastfeeding, and physical activity. She is experienced in designing and evaluating behavior change initiatives conducted by government, non-government, and private organizations. She's conducted numerous qualitative and quantitative research studies on behavior and behavior change, and has conducted large-scale national and international consumer evaluations of health behaviors, including breastfeeding, walking behaviors, and alcohol warning labels. Joy, over to you. I think Joy may be on mute still. Oh, and I forgot to advance her slides. So she advanced her slides to her first slide. We still are not hearing you yet, though, Joy.
Thanks,
there
Jay.
You go.
Can you hear me now?
Yes, thanks.
Thanks for that welcome, Jay. I appreciate that. Welcome to all of our participants in the webinar tonight as well. Great to have you with us. So my talk tonight is this morning, sorry, it's nighttime for me, Socio-Psychological Levers for Improving Women's Health and Wellbeing. So there's many influences on women's health and well-being. There's some important influential social and psychological factors, which include friends and family, communities, and then there's the individual factors, of which only some of these are actually modifiable, and that's what I'll be talking to you about in this presentation. There's numerous key transition points which are important in the development of good or poor health for women. For example, commencing school, when we enter the workforce, or go to university, pregnancy and childbirth, retirement, when our children leave home. So there's lots of different places throughout the life course where changes occur. So I'm going to look at just a couple of points today. The first one being obesity, which there's several transition points throughout the life course where this is applicable. And the second one is childbirth and breastfeeding in particular. So firstly, as we know, obesity is a huge social issue, pardon the pun. It's the third leading cause of illness and early death in Australia, just behind smoking and hypertension or high blood pressure. And Australia is the fourth fattest developed nation. So this is a huge problem, not just for Australia, but many other developed nations. And increasingly, it's becoming a problem for developing nations as well. So what I'm going to talk to you about tonight is the Michelle Bridges 12-week body transformation. So you're probably wondering, who is Michelle Bridges? Well, in Australia and the US and possibly other countries throughout the world, there's a television program called The Biggest Loser, which is about helping people to lose weight. And these are usually very overweight or obese people. So Michelle Bridges was one of the original personal trainers that worked on the Australian program, and she, off the back of that, started her own online body transformation program. Started about 7 or 8 years ago. And that program actually runs for 12 weeks, and it involves both physical activity, healthy eating, and then and mindset as well. And of course, these factors help to reduce the risk factors of developing type 2 diabetes, hypertension, and other cardiovascular type diseases and cancers, etc. So there's a whole range of different health issues that this helps to reduce. So the 12WBT program has 4 weeks of pre-season and then a 12-week program. There's 14 fitness programs, and then there's 2 other programs as well for pregnant and breastfeeding mothers or post-birth mothers. Then there's nutrition plans and mindset lessons in there as well. So there's a range of, the program consists of not only weight loss programs, but strength training programs, running programs. So there's a range of running programs from beginner to learning to run a half marathon to learning how to run a full marathon, for example. As I mentioned, the pregnancy and post-baby programs. And there's also two new programs called Move and Move 2. Now, these two programs are specifically designed for obese consumers, and they're just to introduce them into changing their way of thinking. So they don't throw them straight into 1,200 calories a day eating program. They start off much higher so that they can slowly reduce that down. And they also start off with very gentle physical activity. For example, the first week they might just start taking a little walk around their home. The second week they might then start taking a walk around the block 3 days a week. And they slowly increase that exercise intensity over time. So it's really tailored to meet them where they're at. And these programs are all developed by scientists as well, so it's all evidence-based. So the first part that I'm going to talk to you about is the physical activity, nutrition and mindset, which is the three elements of the program. In social marketing, we use social marketing practice, we always use the 8 benchmark criteria to underpin our programs. And of course, one of those criteria is theory. And this program is underpinned by self-efficacy theory, which is the person's belief in their own ability to perform a behaviour. The self-efficacy affects their choice of activities, the behavioural settings, how much effort they expend, and how long they'll actually persist in the face of obstacles or difficulties or aversive experiences as well. So the stronger the perceived self-efficacy, the more active the coping efforts that these people will actually make. So there's a range of tools in the Michelle Bridges program to increase self-efficacy. There's at-home workouts. These are all available online. There's an app as well, so that and with videos that actually shows them how to do each exercise so that they have correct form, so they're not going to injure themselves. Then on the nutrition side, there's a weekly meal plan, which is tailored to their specific requirements. So they're tailored for all of the different programs. And attached to that meal plan is recipes and also a shopping list. And the beauty of the shopping list is that it's also attached to Woolworths Online, which Woolworths is one of the largest supermarket chains in Australia, and they do online on home delivery. So the actual shopping list that matches with the meal plan is then linked to the online shopping, which then reduces the time that people have to spend, which of course reduces another barrier to participation in the program. So it's very well thought out. Then there's an extra ingredient. Michelle Bridges promotes her program on this extra ingredient. She says, losing weight is a science. Keeping it off is psychology. It's all about mindset. Mindset's overlooked in so many weight loss and fitness programs, but it really is the most important factor. And it's what sets my 12-week body transformation apart from any other program out there. She also has a catch cry, which is JFDI, just frickin' do it. So she really encourages habit formation and getting people just to, have their runners or their tennis shoes or their joggers beside their bed, so that in the morning they can just roll out of bed, put them on and get out and start exercising without any excuses. So a lot of the programs built around creating new habits for people so that they can change their lifestyle over time. And while it's a 12-week program, because it's a commercial program, it's ongoing, so it's sustainable. So if people can do it for one round, they could do it 3 rounds in a row. They might stop for 12 months, but then they can come back and participate again. So, if they start to fall off the bandwagon a little bit, or, feel like they're not eating as well or not exercising as much, they've lost a little bit of motivation, they can actually tap back into the program to reignite that motivation. So the study that I've been doing with this group, and the reason I started looking at them, I've been working with them for about 3 years now. I could see how well the program worked, and it was all scientifically developed because they used accredited nutritionists, and exercise scientists and qualified personal trainers and psychologists to develop the program. And I could see that it was using all of the benchmark criteria that, we promote in social marketing. So I approached them to evaluate the program, and of course they were happy to have a third party do that. So I've been working with them across that time and learning a lot from them as well. So the study that I'm looking at tonight is just 2 rounds of participants and looking at them at time 1, so when just before they start the program, and then at time 2, which is when they complete the program at the end of the 12 weeks. So we have 899 12WBT participants, and then we had a control or a comparison group as well, who also had a weight management goal. So they had high levels of motivation, and they may or may not have been participating in some sort of different program, whether that was Weight Watchers or something at their own gym, for example, but they weren't participating in the Michelle Bridges program. And these participants all completed both study 1 and 2 surveys. So when we looked at self-efficacy, we can see that the Michelle Bridges group actually increased their self-efficacy over the 12-week period. The control group did slightly, but the Michelle Bridges was a significant increase. And the same with their self-efficacy for eating healthfully as well. So we can see that the programs really had an impact on their confidence. Then we also measured the number of home-cooked evening meals per week as well, and we can see that the Michelle Bridges people maintained that or it slightly increased, whereas the control group actually dropped off over the 12-week period. And then when we're looking at the exercise in the past week, that increased for the Michelle Bridges group as well. So what we learnt from this study was that commercial programs demonstrate behaviour change. We can see that there has been some behaviour change. There's a lot of measures that I haven't shown you, of course, in this presentation, but there were some significant behaviour change. And so providing tools to increase self-efficacy and support behavioural adoption is important, and we can see that from these results. So the next part that I'm going to talk to you about is the support forums that the Michelle Bridges 12-week body transformation used. And we know that social support is really important for a whole range of individual behaviours because it really assists people to stay on track. So this is the paper that was just had accepted for publication this year, looking at online support for vulnerable consumers. So it's looking at value co-creation in online support groups. So first of all, we looked at social support, so looking at information support, tangible assistance, so that could be providing people with other recipes or links to different websites or other external help. Esteem social support, which is where people are offering encouragement to people when they've done a good job or if they're struggling a little bit. Emotional support, which is just a little step away from that. And then network support, which is that creating that community of like-minded people. Then we have value co-creation using consumption's value theory. So we found emotional, social, and functional value in there. So our methodology we used for this, so this was the online forum, and we pulled off 2 weeks of data. So we had over 15,000 posts, with 3,149 users, which was quite a large sample. And on average, each of these participants had lost about 3.5 kilograms as well across the full 12-week period. So we, as I said, we used that ethnography approach. And what we found, we used LIWC, which is a linguistic inquiry tool, which has been developed by psychologists to analyse the data because we had so much data, so we really needed some software to help us with that. And what we found in there was really interesting. We could see across the different weight categories, so overweight or normal weight, overweight, and then the 3 classes of obese, that the more obese someone was, the less transparent they were. So the obese class 3 were the least transparent or least honest with their communication, which was really interesting. And then as the participants' weight was reduced and they, going back down through the categories, they became more honest and more transparent, which was really interesting. So we could really see that, this became a really safe place where people could be anonymous and actually talk freely about their struggles and feelings. But it took time to build that trust. So when we looked at social value, I've just got a couple of examples here that we pulled out. It was definitely bidirectional. So there was seeking and giving or providing that social value. So you can see in seeking here, hi guys, I've just moved to Cremorne in Sydney with my family. I'd love to get a group of like-minded programmers who live and work in the area together so we can chat, do some training together and keep each other motivated through the next upcoming 12 weeks. And then one that was giving, welcome on board and thanks for sharing. If at any stage you feel like you're at risk of giving up, please share what you're going through. We are all here for you and believe in you 100%. So that the giving there was provided by the organisation, whereas the seeking was the participant. Then emotional value, that was bidirectional as well. So we had both seeking and giving or providing emotional value. So there was a real recurring theme of people saying that they were, scared to fail or that they were, afraid, and it was really difficult for them to get started. And then we had giving. So well done on taking the first step, Crystal. I'm quite nervous about failing, but also excited as well, so I know the feeling. So we can see how they're really sharing, some of their emotions. And then in giving, once again, I've missed being amongst the team here at the program. I considered trying it on my own this time, but I know how much the support of this program helped me accomplish my goals of developing a healthier lifestyle. So here I am. And then we've got functional value. So receiving, thanks for all your messages, ladies. Great to hear what everyone does to fit in a workout. And this is great advice. Thank you. And there was a multitude of people saying thanks for, or asking for different advice and then saying thank you for that advice as well. So you can really see how that value is being achieved there in that exchange. And then we had giving, and this comes from the organisation as well. And the lowdown on that can be found in these frequently asked questions. So just a brief summary of the text analysis of those first 2 weeks. So we had the 3 dimensions of value: emotional, social and functional. So in emotional value, the social support dimensions were emotional support and esteem support, which were both consumer generated. And then in social value, we had network support, which was service generated, whereas the community support was consumer generated. And then in functional value, we had informational support, which was consumer generated, and instrumental support, which is a little more formal, was service generated. So we can see that, we could see across time how that support actually shifted from being service generated to being consumer generated, and we could see how the power actually shifted in that value co-creation as well. So it shifted from the service provider or the 12WBT team to the actual consumers, and they actually started to share a lot more, and there was less interaction from the actual service providers. So that the online facilitators who are personal trainers and nutritionists, etc., depending on what the questions are and the threads are. So it was really, really quite interesting, and that exchange of social support was really evident, and also the bidirectional nature of the support value co-created. So it was really a giving and receiving exchange relationship in the support groups. And as I said, we could really see how that power actually shifted from the service provider to the consumer. which is really important. So moving from that service dominant logic to more of a consumer dominant logic. So the next thing I'm going to talk to you about is breastfeeding and the Mumbum Connect program, which I was involved in, and I'll talk a little bit about the team further on in the presentation. So Mumbum Connect was the use of SMS text messaging and social media to provide social support and self-efficacy to increase breastfeeding loyalty. So breastfeeding levels are quite low in Australia, and they're low in most Western or developed nations, and also in developing nations as well. For example, only 71% of babies in Australia are breastfed at 1 month, and then by the time we get to 6 months, it's about 14%. And while some of those figures there are from 2008, it hasn't really changed at all. Still very low. We have very high initiation rates, which means that a baby is put to the breast within the first hour after it's born, but then there's not that continuation of the behaviour. And by 6 months, the majority of babies are not receiving any breast milk at all. So women know that it's good for their baby to be breastfed, so that it's not a problem with knowledge or attitude, but there's other barriers that actually prevent them from breastfeeding. And, there's a lot of perceptions around lack of supply, painfulness, and other medical reasons as well. But the percentage of babies or women who can't breastfeed because of medical reasons or actual lack of supply is actually very, very low. So there's a range of approaches that are usually used, and quite often they're educational-only campaigns. And they haven't actually increased breastfeeding behaviours at all. Even the introduction of the UN or WHO's Breastfeeding Friendly Hospital Initiative hasn't really helped too much either. There's quite a low uptake of that program across countries. Australia is very low. There's only around 68 hospitals that actually have it in Australia. It's very, very low. So it's not helpful either. And, non-government organisations, governments and health professionals typically use awareness and knowledge type campaigns to increase breastfeeding rates. So, telling people what they should be doing or putting up posters or handing out brochures. And they promote the breastfeeding as being a simple, doable behaviour. And unfortunately, that's quite often not the reality for women. It's actually very difficult, and it's a learned behaviour. It doesn't always come naturally, and it does take time to learn how to do it. And often women in focus groups agree to lovely rosy images, but this, when they're developing these types of brochures and posters, but it often denies the actual breastfeeding challenges and the difficulties for women. And there's also a failure to personalise the message as well, because everybody has a different experience. So, why haven't some of these approaches, achieved the target rate? Because they're, just using education-based approaches. Now, you can see on the screen at the moment a beautiful poster of a woman who is breastfeeding her baby when she's in her bridesmaid dress. And I know we don't have a lot of women on the webinar tonight, but as a mother, I can assure you that it's not that easy. And I know when I had a small baby, when one of my best friends got married, I certainly was not sitting there, elegantly breastfeeding my baby. Milk leaks everywhere and it's uncomfortable, so it didn't look like that as well. So these types of campaigns are very baby-oriented rather than mother-oriented, and they position breastfeeding as easy, and they often induce guilt because women think that they should be able to do it, whereas it's actually very difficult, as I said before. So these types of education programs elicit a range of different responses from consumers, ranging from irritation to outrage, as we'll look at an example now. So that program, that poster that I showed you was a campaign that was held in Queensland, here where I come from, a few years ago, and then it caused all sorts of outrage when they released it. So this was a headline here in our local newspaper that "Fed up with breastfeeding Nazis. Women who've just given birth do not need the extra stress placed on them by this taxpayer-funded campaign. I will not be made to feel guilty by the government for something I decided as a parent was best for my child." This was one of the comments on the story around it. And it caused all sorts of outrage. There were hundreds and hundreds of comments where people were really upset from both sides, whether they could breastfeed or not breastfeed. They didn't want to be told what to do, and they didn't want to be made feel guilty. So comparing mother-centred with baby-centred factors, we know that there's conflicting evidence that baby-centred factors such as attitudes towards the benefits of breastfeeding for the baby, and also subjective norms, so what other people think about us as women breastfeeding, influence our breastfeeding intentions, and then these intentions predict behaviour. But the gap, or what we don't know, is what role mother-oriented factors such as social support and self-efficacy play in influencing intentions to breastfeed and behaviour compared with attitudes and subjective norms. So our research question for this study was, what influence do mother-centred factors of personal social support and self-efficacy have on breastfeeding duration in a social marketing context? So this was part of our formative research stage. So we looked at 1,100 women in Australia and the US. The mother-oriented factors such as social support and emotions and self-efficacy had a much stronger relationship with the breastfeeding behaviour compared to those baby-oriented factors, which were things like, knowledge about the benefits to the baby and attitudes to breastfeeding. When we removed social support and self-efficacy, those factors were actually quite strong, but when they were all included in the model, they just fell away. So the strong relationship between negative emotions and breastfeeding intentions also demonstrates that women want to avoid feeling those types of emotions, things like sadness and guilt, shame, anger, when they're actually making infant feeding or breastfeeding decisions. And breastfeeding is more likely to be adopted when a woman actually has some sort of emotional attachment to the behaviour, and they think that they've actually got social support of their adoption of that behaviour as well, or the breastfeeding behaviour. We know that support from the woman's partner or husband is really crucial for that breastfeeding relationship. And once again, this paper here reports the findings of this study. So as I said before, attitude and subjective norm are really strong on intentions and behaviour when we don't have anything else in the model. But as soon as we introduce self-efficacy and social support, we can see that attitude and subjective norms actually drops away. So self-efficacy is mediating that relationship between social support and intentions as well. So what needs to be in place for mums to breastfeed to 6 months? So what are the actual modifiable factors? So we've got self-efficacy and social support. Then there's a lot of other factors that aren't modifiable, such as their perceptions of social support, their own experience, from growing up and being maybe exposed to breastfeeding as well. So we can't change those in an intervention, but we can assist with self-efficacy and social support. So our theoretical background included self-efficacy and social support. And social support usually refers to the roles performed by, significant others, such as our family, our friends or relatives, neighbours, can even be health professionals as well, or our partners. And that solid support actually validates the behaviour and reduces that anxiety around the behaviour as well. And we found that when women have good, strong social support, they're more loyal to breastfeeding. So we've applied quite a few consumer behaviour and commercial marketing theories to our breastfeeding context as well. So we did some focus groups as well to build further on our formative research stage. And we found, when we looked at mothers' baby feeding experiences, that breastfeeding was hard and it hurt. That quite often breastfeeding feels like it's the only option as well. Women felt that they had breastfeeding forced upon them. And then if they can't breastfeed, that they failed, and they failed as a mother, that they're a bad mother. There was a perception that midwives don't know what they're talking about as well. They weren't very confident in some of the health professionals. And there needs to be advice for those who bottle feed as well, so it can't be exclusively around breastfeeding. Then looking at the relationships that facilitate breastfeeding, our research supported that. Family and partner support is essential, and it doesn't matter what choice that the mother makes, that their partner needs to be supportive. They also agreed that professional help was really crucial, and they also needed more time, more face-to-face time with professionals, so that they could actually exchange some of that information and talk through some of their problems. And they also used a variety of different sources to find their information as well, a lot of online sources. In Australia, we have the Australian Breastfeeding Association, which is a not-for-profit support association that offers counselling. While not many of our mothers actually had any contact with them, but those who did, they mostly reacted negatively. They found that they talked about them as being breastfeeding Nazis as well. So they didn't want to interact with them at all. And women also wanted independent advice that helped with feeding issues generally, whether they were breastfeeding or bottle feeding. So there were some key themes that kept recurring as well. So our solution was to have a non-education-based campaign to improve breastfeeding duration or loyalty, which led to the development of our intervention, which was a partnership between the Australian Breastfeeding Association and QUT. So we started all of this foundation work way back in 2008. And this was working with my colleagues, Professor Rebecca Russell-Bennett and Dr. Danielle Galagos from QUT and Dr. Josephine Previty from UQ, all here in Brisbane. We also had Andre Laporte, who was our creative director, and Robin Hamilton, who was the ABA representative as well. So I'll just move quickly. I'm quickly running out of time here. I could speak to you all day about this. So our intervention brief was to be mother-oriented, personalised, digital, and have positive support rather than guilt. And then we came up with the name Mumbum Connect, which was specifically designed to appeal to mothers from a wide range of socioeconomic backgrounds and geographic areas. So it was meant to appeal to people who lived in a city and also in more regional and rural areas as well. And it was based on the understanding that mothers are really time poor, but they also want information as well. So this is our brand that we came up with Mumbum Connect. So it was, quite identifiable. And the green represented nature and growth. Apricot represents the mother's skin, health and vitality. And the grape represents youthfulness, fun, sweetness, and modern dynamics. And you can see that the little logo there is the mother holding the baby without actually breastfeeding. She could be bottle feeding as well. So we came up with a digital intervention, which we had a website and also a two-way automated text messaging service, which was a world first. So it took quite a bit of work to get it right, but we used quite a complex algorithm in the background. So it was based on keyword recognition and response. So we would send out a little message, and then the mothers had some keywords that they would respond back, and then they'd receive a response back based on their keyword. And these messages were sent out once a week. So you can see the keywords there on our contact card. So they had a fridge magnet and a little wallet card as well, so it was easily accessible for them. And we also had a website which had a range of information and key contacts as well, and a Facebook page as well. And we also had support provided by the Australian Breastfeeding Association counsellors. So we actually had outbound calls if someone texted in that they were feeling stressed or depressed or something like that as well. So we called them, got the counsellors to call them straight away. So we had 130 women who were registered, and we only had 6 women who actually pull out, which was quite good, quite high retention rate. You can see that the top line is Mumbum Connect. So we actually had much less drop-off in breastfeeding behaviour across the 8-week program than the Queensland average, for example. So it worked really, really well. It actually achieved what we set out in maintaining behaviour. Of course, we're not going to increase it, but we did maintain behaviour. These are some of the differences. You can look at these slides when they're available in a couple of days. So there was a really overwhelmingly positive response, and some of the negative responses or areas for improvement were that women would really have liked the ability to generate the SMS messages themselves, so having some sort of free text rather than using the specific word. But we, just didn't have the money to develop such a complex response system. And some of the women also said that they didn't get enough messages as well. But some women worked out that if they sent a keyword every day, that a different keyword, they would get a different response. And that algorithm that we had set up was set up so that there was different responses, that the women wouldn't get the same response twice. So it was, quite scientific. So here, this is the reference to the results of this particular study, if you would like to have a look. Thank you very much. That is the end of my presentation. I hope that was helpful for you all.
Thank you. Thank you very much, Joy. I find a very inspiring presentation with a number of programs with great results and great approaches. So go ahead and put your questions in, those of you who are participating. I have a number here in front of me, and there's certainly room for some more questions as well. First of all, I'd like to ask about, you mentioned the very first program that you were talking about, the commercial program, and that people could come back to the program. Do they have to pay again when they come back, or is it like, you pay once and then the support is there from then on?
No, you pay each time that you come back. So it's 199 Australian dollars for the 12-week program, which gives you access to all of those, the exercise programs, the nutrition programs, and the mindset lessons as well. And you download the ebook of recipes as well, so you can keep them forever. I mean, they change every round as well. They introduce new ones. But no, you do have to continue to pay. But a lot of the female participants actually, are happy to cycle back in, as I said, when they feel like they're falling off, or they need a bit more motivation. They might have put on a little bit of weight, for example. So the beauty of this program, or these types of programs, are that they are actually self-sustainable, and these, people can cycle back in, because obesity is a problem like type 2 diabetes or diabetes that we need to actually manage this across our lifetime. So it's an ongoing issue. So it's really important to have programs that people can actually join back into.
And in your evaluation, did you in fact see people cycling in that way?
Yes. At the first round of data collection, we had people who had participated in the program. This was their first participation, up to 14 rounds of participation. So and we've done a lot of follow-up interviews with these people as well, and they they love to, keep coming back. But some of them, it's just a way of being organised so that they feel like they can eat healthily all the time.
Now, this works on a commercial basis for people who pay for the service. Could you see that approach being scaled up and used in a non-commercial way in reaching, for instance, poor segments of the population?
Yes, I can. I see, and this is the reason I started looking at this program, because I thought that, they're using all of these commercial marketing techniques to do what we social marketers try and do all the time on a shoestring. I think that we can develop some of these types of programs or make them sustainable over time by actually, introducing social enterprise. So actually having these people take ownership of some of the programs so that they can be sustainable over time, which might mean that there's peer training, to actually deliver the program.
Yeah, absolutely. Can you tell us a little bit about how you measured self-efficacy?
So we use validated measures, and you can see that in the papers as well. So they're very similar questions, just adapted for the different behaviours. But they're just validated measures which are based on Bandura's self-efficacy.
Okay.
So I think we use 3 different questions to actually measure it in the surveys.
Great. Would breastfeeding women get tired of getting SMS messages or ignore them if they were to receive them for a long time?
Yes, I do think there would be some fatigue if they received them for too long. So our program only ran for 8 weeks. And with breastfeeding, usually there's a kind of critical point where women really struggle, and that's where they drop off. And that, can be anywhere up until 12 weeks, the baby being 12 weeks of age. So having that 8 weeks assists them to actually get through that difficult period. So it's not too long, but it's long enough as well to help them through so that they can actually become more confident in their own ability to make decisions or to seek information, because they're starting to understand how that breastfeeding relationship works, and when something doesn't feel right or when they don't feel that the baby's doing quite what they should be doing, they can actually then start making some decisions. As I said, some of the women wanted more messages, and then others said it was just right just having that 1 a week. And for that 8-week period as well, so they didn't get tired of them and start to ignore them or wish that they'd go away every time that they got a message. They didn't start to curse their mobile phone.
You've talked about a number of things that they did to make things easier, provide social support. What kind of tools did they use to, once people were involved, to engage them further rather than seeing them drop out, if you like, and come back?
So
even.
Was that
I would ask the question generally. Did you see some interesting approaches in any of the programs that are worth going back to talk a little more about?
Well, I think with the 12WBT program, they don't actively chase people if they find that they drop off. There is a significant drop-off at the 3-week mark when people have been participating in the program at 3 weeks, because quite often they think, oh my goodness, I haven't lost any weight yet. So they start to struggle and lose their confidence. They do have a range of communication tools that are mostly just one way. So they might send a text message and say, we've noticed that you haven't done your fitness test, or you haven't updated your, entered your weight this week, or you haven't logged in to get your recipes. And they also send emails as well to help re-engage people. And they're looking at developing further systems to assist that as well, and just testing different things.
Interesting. What about the use of tools like prompts and commitment techniques. What did you notice in the programs that way?
Yeah, the Michelle Bridges 12-week body transformation actually in their online forums use commitment threads, and I believe they also send emails when people are starting as well to get them to make a commitment. And some of those goals can be concrete and some are more abstract. So the more concrete goals or commitments that the women make are things like, I want to lose 5 kilograms across this 12 weeks, or I want to be able to run 5 kilometres at the end of this 12 weeks. Whereas the more abstract goals might be, I want to be able to fit into a nice wedding dress in 12 months' time, or I want to be fitter and healthier so that I can run around with my children. So it's a really important aspect, and I have actually done, which I didn't talk about in this presentation, that I have actually looked at that goal setting and the motivation as well, and the desires, and how that leads to intentions and then subsequent behaviour as well.
Hamilton has put in a comment. He says, I think implementation intentions is an interesting intervention to test in both cases.
Yeah, I agree. Absolutely agree, Hamilton.
I have a question for you also about the type of research you were doing in the one program with social media. You were looking at text analysis. Can you compare the expense of doing that kind of research to more traditional formative research?
Yeah, it's actually quite cost effective. We scraped the forums, and that didn't really cost us anything, and we used that LIWC software as well, which was actually quite quick and easy to use. So it's quite a cost-effective way to collect, to analyse a large amount of data that didn't really cost us any money at all. The organisation just downloaded that for us and gave it to us. So it was, quite cheap. And you can do that in a range of other forums or online type of forums as well. So whereas when you do survey research, if you are using panel data, for example, through something like Qualtrics, you can be paying $5 or $6 per participant, so it becomes very expensive. So this was actually very cost effective to get a lot of information in a very short period of time too.
And what was the main
main
limitation from doing it that way? You're selling us on the cost advantage. Is there something that you, what would you say about the other side?
In this, when you're scraping website data or social media data or online forum data, you don't have any input into what the topics are that they discuss, because it's more, ethnographical and observational. So it's allowing people to be in their natural habitat or their natural environment. So you're following conversations that have naturally occurred. So there's no researcher participation there. So sometimes you might not be able to find out things that you're looking for because the question hasn't been asked. So you're just analysing what that natural conversation is.
What do you think of having a confederate go in and ask some of those questions so you do get answers?
Well, I guess then, I suppose you just have to be very upfront about that. But I think people don't, if people smell a rat, I don't know, I'm sure you know what that saying means,
yes.
Then they don't tend to be as honest. And that is actually one of the strengths of these types of data or research tools, is that you're observing people who are likely, or you're reducing that social desirability bias and allowing that natural conversation to take place. So hopefully people are being more transparent and honest, so that you can actually see what's going on.
Great. Well, I see we've come up to the end of our time, so we're going to have to move into our final section here. And I'd like to thank you for, as I said, an inspiring presentation, and also thanks to all of the participants in today's webinar. As you're leaving today, please do fill out the survey. You should be asked to comment on the webinar, and even if you've been in our webinars before, that lets us know how we did today and how things are going. I'll remind you about upcoming events. We have a number in July and in August as well. For those of you in the UK, September the 14th, the UK Social Marketing Conference. And then, of course, our next webinar in the series, September 19th to 20th, Designing Quality Engagement into Social Marketing Campaigns with Julie Kohlauer from CNC Seattle, Washington, USA. So registration is already open. Go ahead and sign up anytime. Lastly, I'd like to clear my voice and thank Susie Coppathorne, who is our technical host for the first time in this group of 2 webinars. Thank you so much, Susie. You've done a great job. And, of course, also to Patrick Cook, our new president. Thank you for stepping up and for doing the webinars with me now. Patrick, over to you.
Great. Thanks very much, Jay, and thanks, Susie. You guys have done a remarkable job in pulling these webinars together, and I know a lot of work went into getting things in shape for today's webinar. Also, Joy, thanks again for your amazing presentation. It was very insightful and inspiring. The Socio-Psychological Levers for Improving Women's Health and Well-Being, I think, will be one of our more popular archived webinars. And I also want to thank our members and participants in today's webinar for joining us. If it's early in the morning for you or late in the evening, we appreciate you taking the time. Of course, Jay mentioned we have another webinar coming up in September, which we hope you can join us for, Designing Quality Engagement into Social Marketing Campaigns. So until then, please do check out our website, isma.org, where you can find events and look at possible career options. So again, thanks very much. This is the International Social Marketing Association, and we now conclude today's webinar.